is the region of the hand. By this, all the material which is included in your midterm exam will be finished. These two regions, as you remember, region of the thorax, the region of the upper extremity. Your group number?
201.
01. I don't remember. Isa told me that if I don't mistake, you will pass in your day of the lesson. For one group, I don't know for which one group she changed the time for the midterm examination. I don't remember. To tell the truth, that is not my problem. That is the questions of the dean office. Yeah, that's it. Sure, she will inform you. Yeah, I don't know. If I don't mistake, it's not belong to you. You will pass it in the time of your regular lesson. Yeah, time of your regular lesson. For all the groups I told it, for you also I want to mention that if you want to answer today or during the next week after your controlled work, I'm ready to organize it for you because your daily marks is not so high, so who need to improve it because you will not have any other controls, something like this. Don't forget that the Saturday, it is the deadline of your individuals. Guys, it's not because I'm bad, but I need the time for calculation. Whole my Sunday, I must calculate your scores, means from your attendance, from your individuals, from your daily marks, yeah. So I must, but guys, remember the single rule. If your final score will be less than 26, it will not be effective to come to the second midterm exam because maximally you can achieve 25, and you know that the minimum positive mark it is 51. So I think it is very simply can be calculated in your mind. Yeah, up to the 10, you can make the summary. It is not the problem. Say the people who don't have the normal attendance, who don't have the daily marks, who don't have the individual works, anything else, passage of the second midterm is not necessary. As you understand, because even if you will achieve the 10, that means 25 points, you will not have your 55, for attestation. I think it is a mistake. That's all what I want to tell you now. Immediately I will start to explain for you the new topic, write the region of the hand. And give me 1 minute, number of group.
201.
1 minute until I will check your attendance and all. Did
8.
Am I have today absence?
No.
No, yeah?
No.
20 persons.
Yeah.
Everybody here. What structure of your test? I told you before, 2 oral questions. 2. I will not put the 3. It will be 2 questions. You know that the operative surgery of upper extremity will not be included. It will go next semester. Especially, I decided to not make the lecture in this week, right? Because I think it's not effective to give the region which is not included in your midterm exam. Yeah, we'll have more than enough time in the next semester to read for you, for example, topic of the lower extremity. Say today also we dismiss our lectures because that's not effective. You must attract your attention into material of this midterm examination, not about the next one. Let's say one question will be from thorax. Randomly, again, it can be operative question, it can be topographical questions, I don't know. One question strongly will be from upper extremity. Strongly with upper extremity. That's all. If no questions, let's start because time is short. Maximally listen, minimally write if it will be necessary. Okay, we come to the terminal portion of the upper extremity, which is called the radial manus or the hand region. And it has the borders, only one border, upper border, which is the same to the lower border of the forearm region. As you remember, 2 centimeter above the styloid process of the radius, you provided the circular line. It means anterior and posterior regions is equal to each other. By the way, from anatomy, I want to remind you guys that then you compare the metacarpal region in palmar and in dorsal surface, they are not symmetrical. If you will look to your hands, you will see that upwards it goes much more bigger, much more lower, not up but down, because that is the position. Yeah. Let's say palmar surface is bigger than your dorsal surface. Let's say you will come or not?
Yeah, I will come, but we need to get it stopped from the doing.
Do it. But that is not the option. Why it's happened, you know, yeah? Because the proximal heads of the fingers, it's located in the distal region a little bit more upwards. Let's say it is a little bit asymmetrical from that point of view. Then you look to anterior and then you turn it to the posterior. It is come approximately to the level of the midpoint of the phalanx. So this is need to be mentioned. Keep in your mind. Okay, this is the border of the region. I show now that circular line. Then you provided 2 imaginary lines. One goes along the medial margin of the hand up to the medial margin of the 5th finger. Second goes by the lateral margin up to the lateral margin of your 1st finger. And by these 2 imaginary lines, all hand region split it into the palmar and into the dorsal compartments. Again, I say absolutely equal to each other. Then you take it commonly, yeah, not compare the separate regions to each other. Okay, now let's start from the anterior compartment, which we call the palmar region. Layer number 1, skin. If you want to give the characteristics of the skin, you should mention that we have absolutely 2 different kinds of the skin. Second kind of the skin, first kind of the skin, located in the level of the wrist joint, above the real palmar skin region. And if you look to here, you will see that skin in this region has horizontal folds. Skin of this region is elastic and movable. Skin of this region in the lateral portions for the males have the hairs, sweat, and sebaceous glands. Then you descend it to down, you see absolutely another skin, which is much more thicker. It is not elastic and not movable. It doesn't have so much sebaceous. It primarily contains the sweat glands, not any hairs, and huge amount of receptors. That is the receptors which is provided your tactile sensitivity. And if you look in the surface of the skin, you will see a lot of the grooves, which is located in different directions, and which is show for you the place of attachment of the septus, originated from proper fascia and fused with the inner surface of the skin to make it thicker, to prevent its elasticity and movement. Let's say, in your culture, for example, I know that you give some sacral meaning, yes, some of you, yeah, for these folds, but in reality, it is just the septus, nothing more, which is originated from the proper fascia, which is come to the inner surface of the skin and fused with that. Okay, subcutaneous fatty tissue, again, as for the skin, I must divide it into 2 compartments, in the region of the wrist joint and in the real palmar region. In the region of the wrist joint, the fat is not so good developed. The fat is not good developed, it doesn't have the septa, it doesn't have the pocketer structure, and it contains superficial vessels and nerves. First of all, about the vessels, you know, it is the 2 veins. Medially we have basilic one, laterally we have cephalic one. And what is interesting, guys, exactly immediately in the level of the lower horizontal fold, because here we have 3 horizontal folds on the skin. In the level of the lower horizontal fold, both these veins leave anterior region and they come to the back. And after then we will start to discuss the back region, yeah, dorsal region of the hand. You will see that they forms here the venous network in subcutaneous fat tissue. By the way, in my finger, in your fingers may be much more better. You can see, yes, some venous structures which is located in dorsum of your hand. One of the most comfortable place for the intravenous injections. Yes. From this network in the medial side, we have origination of basilic vein. In the lateral side, we have origination. So remember, please, these two veins originated in dorsum of the hand, not in the palmar surface. But after they come to the anterior regions of forearm, anterior region of arm, anterior arm, cubital region, let's say, they totally interior structures except the place of the origin. They originated in the back. Okay, in upper part of the region, except these two veins, also we have superficial nerves inside of the subcutaneous fat tissue. Absolutely same, guys, to the lower forearm region. As you remember, medially medial skin nerve of the forearm, laterally lateral skin nerve of the forearm, posteriorly posterior skin nerve of the forearm. All these structural units you know, medial from medial cord, lateral it is musculocutaneous, posterior it is from radialis. But then you come to the real palm, sedation is happened, all that nerves is finished in the level of the same lower fold. And inferiorly, you have the picture which is shown in the lower one. It is two colors, the green color and the yellow color. And that is the source of two nerves. In the medial side, we have the superficial branchings from nervus ulnaris. And in the lateral side, we have the superficial or skin branches of nervus medianus. And here, you know, majority of the cases, approximately 70%, we have something like 1.5, 3.5. 1.5 finger with corresponding palmar surface supplied by the ulnaris in the medial side, and 3.5 fingers together with the corresponding portion of the palm supplied by the medianus. By the way, main trunk of these both nerves located deep under the proper fascia, but they give the superficial branches, which is perforated proper fascia and come to the fatty tissue to supply the skin. They form the huge network inside of the subcutaneous fat. Why? Because again, I tell you, this is the sensory zone of the human organism. There are a lot of the receptors that say they must make this innervation. So remember, please, once again, many times I told you, it will be in your exam. Structures which is in fat, we call superficial. Structures which is under the proper fascia, we call deep. Let's say these main nerves, and yellow one and green one, it is deep structures.
Yes.
They located under the proper fascia. But each one gives the superficial branch, which is come to the subcutaneous fat and make the innervation. What else we have here in the fat except these two nerves? Of course, we have some tributaries of cephalic and basilic vein. We have superficial lymphatic nodes, and we have the septas, which is originated from proper fascia, traverse through the fat, and fuse with the inner surface of the skin. Due to it, here we have the pocketer structure for the fat. That's inflammational processes usually separated in this region. Okay, let's continue. Inside of the fatty tissue, in the medial side, we have one superficial muscle, which we call musculus palmaris brevis. You remember the long palmar muscle located in your anterior forearm region. By the way, like the muscle, it is presented only in upper third. In middle and lower, it has the tendon form. As you remember, it's located in the first layer of anterior muscles, together with flexor ulnaris, radialis, pronator teres. It's located in the first layer. But short one located in fatty tissue. This is unique situation, guys. Then we have superficial muscles as platysma, for example, in the neck region. These superficial muscles are covered by superficial fascia, not by the proper fascia, as usual our skeletal muscles, but with the superficial fascia. And it's located in the medial side. Musculus palmaris brevis. Also inside of the fatty tissue, as I mentioned before, we have superficial lymphatic nodes. That's all. Layer number 3, it is the superficial fascia. Its function, I told you, it's cover one muscle that forms the sheet for it. Under it, we have one unique structure, which is greatly visible in this picture. Skin, fat, superficial fascia is removed. And look in this triangular shape of a nephrotical structure with the tip, which is looked proximally, and base, which is looked distally. That is the structure which is originated from proper fascia, and we call it the palmar aponeurosis. Aponeurosis palmaris. How it is originated? Guys, two structures joined to each other. First of all, it is the proper fascia. By the way, proper fascia in your palm is great developed in middle portion and less developed in the medial and lateral portion. And this great developed middle portion fused with the tendon of palmaris longus. You can see this tendon of palmaris longus, which is come from the anterior forearm region. It fused with the proper fascia, and together they forms the palmar aponeurosis. Look attentively in this structure. You can see that it has two types of fibers. Majority of the fibers have the vertical direction. And by the way, near the fingers, they split it into 4 bands, which is go correspondingly from second up to the 5th fingers, yeah? But also, if you will look attentively, you will see 2 horizontal group of the fibers, one approximately in mid-side of the metacarpal region, second in the base of the fingers. So what is happened? These vertical and horizontal bands together forms the apertures. These apertures again located in the base of the fingers, generally 3 apertures, which are called commisural apertures. Hold your hands like this. Hold, hurry up, I don't have time. This is proper fascia. This is, for example, metacarpal bones, yeah? Under the proper fascia, this space, we call bibulus connective tissue. Open now your fingers. This is commisural apertures. By these commisural apertures, subcutaneous fat and bibulus connective tissue will have the communication. And vessels and nerves from bibulus connective tissue by these commisural apertures will come to the fat and will be continuous into the fingers. And a little after you will see that this bibulus connective tissue by the flexor tendons will be split into 2 compartments. Between our hands, now up to my hand, we have subaponeurotical portion. Below my hand, we have subtendinous portion. So remember, please, this bibulus connective, it's not common. It is split into 2 compartments, subaponeurotical. By the way, both is communicated to each other between now my fingers, because my fingers, it is different tendons. But anyhow, we have this division. Thank you very much. Is it understandable for you? So remember, please, commisural aperture forms between vertical and horizontal fibers. If you will open your hand and will look to the region of the base of your fingers, you will see 3 protrusions. This is protrusions of fat, which is covered these commisural apertures. You can ask me why? For protection. Because through these commisural apertures, deep vessels and nerves come to outside, and they should have protection to not be damaged during the trauma. More of this, to not be compressed during your hand works. That's a fat here, it has the bumpering function, and it is protecting these deep structures from compression, from damage, for anything else. That's why remember, please, first structure which forms by proper fascia, it is the palmar aponeurosis. Second structure which is forms again by proper fascia, by the way, you can see it in this picture, portionally it is cutted, portionally it is presented, but much more better you can see it, for example, here. It is very thick tendinous structure. By the way, it's located in the level of the wrist joint. And it is fused with your carpal bones. And together with your carpal bones, it forms the canals. And we call it retinaculum flexorum. Retinaculum, it is fixator. Flexorum, it is flexor tendons. That's it. It is covered, the flexor tendons, which is come from anterior forearm region, and fix them and forms the canals. It's a retinaculum flexorum. Now hold your hands in such way, a little bit more groove shape. Thank you very much. Now let's imagine that our friend hands, it is the carpal bones. I want to remind you that we have 8 carpal bones by 2 rows. Yeah, the proximal one and the distal. For example, her finger region, it is the proximal row, yeah? Palm region, it is the distal. My hand, which I put above, it will be the retinaculum flexorum. And you can see now that we together forms the canal. Let's say she naturally have the groove, which we call the sulcus, yeah, carpalis. And together with my hand, which is retinaculum flexorum, yeah, we forms the channel. By the way, not the channel, but channels. Because you will see a little after that there are 3 canals here. But 1 minute attention. How we call these bones? I don't have time to ask you guys. By the way, primary because you don't have any knowledge. So look, from proximal row, yeah, if it will be my right hand, it will be lateral side, this will be medial side. That is this position. That's how we have the scaphoid one or navicular one, call it how you want. Then second one, we have the lunatum. Then you have the triquentrium. And finally, you have the pisiformis, which is the sesamoid bone inside of the tendon. Then you come to the second row, trapezium, trapezoideo, capitatum, and hamatum. That's once again 4 bones, as you see, in the proximal, 4 bones in the distal. Let's say my hand laterally fused with the navicular one and with the trapezium. And medially it fused with the triquentrium and hamatum. Why not to pisiform? Because again, it's a sesamoid, it is inside of tendon. It cannot be used anything else. Let's say my hand now fused with her hand. Can you give me one more pen? One just. And look, what is important? I give, hold it please between your fingers. I give 2 septas. One in the lateral side, one in the medial. My lateral septa fused with medial surface of scaphoid, and my medial one fused with the lateral surface of triquentrium. And do you see now, instead of 1 canal, we achieve 3 canals. How we call? Canalis carpi ulnaris, canalis carpi radialis, and canalis carpalis. Thank you very much. So remember it, please. The retinaculum flexorum covers the carpal bones. It gives 2 septas. By the way, again, properficial also cover the bones upper surface also. Let's say this canal from all the sides, it is covered by the properficial. Not only from upwards, but from downwards. And also it gives 2 septas. Yes. Let's say 3 canals. These canals, for example, you can find in this picture. It's greatly visible, for example, here. This is retinaculum flexorum, that is the carpal bones, and this is the first canal, this is the second canal, you can see the septa. Third one, unfortunately, is not good visible, but it's located in the lateral side. What is located inside of this canal? Canalis carpi ulnaris contain the ulnar neurovascular bundle, artery, 2 veins, and nervus ulnaris. As you remember, nerve has the more medial position, vessels located a little bit laterally, and through this canal, from anterior foramen region, this neurovascular bundle goes into the palmar region. Again, we have 2 hands, but it goes, of course, into deep loose connective tissue, because it's primarily located under the properficial. Don't forget that retinaculum flexorum, it is the properficial. And it comes to the first part of the deep loose connective, which is called subaponeurotic. And you will see a little after that the ulnar artery inside of subaponeurotical loose connective will form the superficial arterial arch. If you remember, your palm has 2 arches, superficial and deep. Deep one will be subtendinous loose connective tissue, and it will be formed by a radial artery primary. If ulnar one forms the superficial arc, radial one forms the deep. A little after I will tell you how we come to this deep space. But just now remember, inside of canalis carpi ulnaris we have ulnar neurovascular bundle, which is continued to down, come to the palmar region, and located in subaponeurotical loose connective tissue space. Inside of the carpi radial canal, we have only 1 tendon. It is the tendon of flexor carpi radialis. It comes to the wrist joint region and finish here. You remember, if we have flexion of only carpi ulnaris or carpi radialis, it makes the tilt. If you flex both together, it makes the flexion in your wrist joint. So remember, in carpi radial canal, you have only 1 tendon of flexor carpi radialis. Nothing more, no any vessels, no any nerves. Now let's come to the most important compartment, canalis carpalis. Canalis carpalis, it is middle and the biggest part of this canal. And what is located inside of it? First of all, you can see two huge, one is huge, second not so much, synovial sheets. The medial one we call ulnar, the lateral one we call radial. Inside of ulnar one we have 8 tendons, 4 superficial flexors and 4 deep flexors. What does it mean, superficial and deep flexors? I want to remind you that in your anterior forearm we have 2 muscles. One is located in second layer and it's called superficial flexor of the fingers. Then inferiorly it is split into the 4 tendons correspondingly to your second up to your 5th fingers, not to your thumb. Thumb has its own flexors. But in third layer of the muscle, there are one more muscle which is called flexor pollicis profundus, flexor digitorum superficialis in second layer and flexor digitorum profundus, in third layer. It's not mistake, by the way. Third layer content on flexor pollicis longus. But now I attract your attention into flexor digitorum profundus. Let's say it's also inferiorly split into 4 tendons, again from second up to the 4th fingers. By the way, a little bit anatomy. If you will look, for example, in this picture, you will remember that this green superficial tendon come only to the middle phalanx, split it into 2 fibers, and fuse to the 2 sides. Insert your pen between 2 my fingers. Hurry up, hey, don't sleep. Between these 2 legs, deep tendon of the flexors is passed, come to the distal phalanx and fuse with the distal phalanx. That's a superficial tendon fused with middle phalanx, deep tendon fused with the distal phalanx. Let's say then you make, for example, this movement. You use your superficial tendon. Then you make that movement, flexion of the last phalanx. You use your deep tendon. And together they make the complete movement. So this is necessary, for example, in the future to recognize, for example, and make the differentiation between trauma of deep and trauma of superficial. If it will be trauma of superficial, this movement will be impossible. If it will be trauma of the deep, that movement will be impossible. Because last phalanx will lose its flexion ability. Do you understand me?
Yes, sir.
Now attract your attention into this picture, a little bit some review of the histology for you. Then we speak about synovial sheets. First of all, if you will attract your attention in this picture, you will see that synovial ulnar sheet, except the tendon of first finger, interrupted in the mid part of the metacarpal region. Then again, synovial sheets is reconstructed in the region of the fingers. In the metacarpal region, there are part of the tendons which doesn't cover by the synovial sheet. Exception, it is the tendon of the 5th finger. You can see without interruption of the synovial sheet, it is continuous up to the 5th finger, up to the distal phalanx of it. By the way, both these synovial sheets come out from hand region. They enter into the pyragloblus connective tissue, which is located in the lower third of forearm region, anterior forearm. We draw it together. If you will open your cross-finger sections, you will find it. That's why, guys, we need attention. If will be synovitis of your 5th finger, it can easily spread it up to the pyragloblus. But if will be synovitis of these 3 fingers, it doesn't have any chance to pass into the forearm region. Why? Because you can see that synovial sheet is interrupted in the region of the metacarpus. If it is interrupted, infection contagiously cannot be spread into up. Is it understandable for you or no? I'm not sure. Do you understand generally what about I speak? Generally. What about I speak generally? No, generally I speak about human body, Generally. Generally you understand that we are inside of the medical university, It is not, for example, agricultural university, for example. But especially, which topic today I introduce for you?
And he was talking about splitting of tendons.
No, I didn't speak about splitting of tendon. I speak about the separations or discontinuations of the synovial sheath. I don't speak absolutely about splitting of any tendon. I speak about discontinuations of the synovial sheaths. That's for fifth finger, it is continuous and goes from the forearm up to the tip of the finger. For second, third, and fourth fingers, we have two places synovial. First of all, in the level of the fingers, and second, above the midpoint of your metacarpal ridge. Between them, we have the gap of tendons without synovial coating. That is what about this, not about splitting of any tendon. Now attract your attention into the radial one. It contains only one tendon. It is the long flexor of the first finger, musculus flexor pollicis longus. By the way, short one will be in region of thenar. A little after we will discuss these two protrusions again. Both these protrusions located, guys, in deep loose connective tissue. They say deep loose connective contains not only fat, not only vessels, but also short muscles or intrinsic muscles, we call. Thank you very much. By the way, these muscles located by three groups: lateral group, middle group, and medial group. First and last group have the form of protrusion. Middle group have the form of depression. Lateral protrusion is called thenar. Medial protrusion is called hypothenar. And short flexor of the first finger located immediately in the region of the thenar. Do you understand it? Little after we will discuss, but now let's continue to speak about synovial sheath. Now, histology, friends. If you will make cross-section of synovial sheath, you will see that it contains double layer. One is called visceral and it is fused with the tendon. Second is called parietal and it covers the visceral one and forms the synovial cavity. Now she is tendon, her white quadrant is the visceral layer and the parietal layer. Space between us is called the synovial space. Inside of our synovial space we have small amount of the synovial liquid which make lubrication and decrease the friction. Place of attachment of these synovial membranes into the bone we call the mesothenar. And through these mesothenar vessels or nerves pass between these synovial membranes, reach the tendon and supply. Also supply the synovial membranes, of course. Is it understandable for you? Do you understand what about I speak or not? Mesotendon, it is the place of the junction of the synovial membrane to the bones, for example, metacarpal bone. And through this place, from periosteum of the bones, vessels will reach the tendon and will supply nerves also. Is it understandable? Yes. Remember, please, once again, inside of canalis carpalis, we have two synovial sheaths. Biggest one is medial, we call it ulnar. Small one is radialis. Inside of the ulnar, we have 8 tendons, 4 superficial flexors, 4 deep flexors. Inside of radial, only one tendon. It is the long flexor of the first finger. But that's not enough. Inside of the channel, just above the mentioned two synovial sheaths, in midpoint between them, we have the median neurovascular bundle. You remember it is nervus medianus and median vessels. Nervus medianus, it is one of the biggest nerves of the human body. Again, hold your hands. You can see that under the proper fish, it's again come to subaponeurotic disconnected, like the ulnar neurovascular. A little after you will see how they split it into the branches and how they supply the structures which is located in this way. Let's say, remember please, this is content of 3 canals. Canalis carpi ulnaris, canalis carpi radialis, canalis carpalis. Okay, until now we discussed 2 structures which is formed by proper fish. It is the palmar aponeuros and it is retinaculum flexor. I need your hands again. Thank you very much. And again, I will take 2 hands. Now look, her upper hand, it is the proper fish. The lower one, it is the bones. Now, I will push these 2 hands between her fingers, correspondingly, symmetric. And again, I will put my hand between her hands. And these two hands, it is two septas, which is originated from proper fissure and goes to the bones. I'm very sorry. You relax. Yes. Yeah. I'm sorry. A minute. I will give my seat. Okay. Once again, let's modulate it. I'm very sorry. 1 and 2. Now look, this is next two structures, which is originated from proper fissure. It is intermuscular septus, guys, which we have in region in forearm. And you can see that all this space divided into three osteofacial compartments: lateral, middle, and medial. By the way, lateral septa will come to the first, second, third metacarpal bone and will be fused with the medial surface of it. Last septa will come to the fifth metacarpal bone and will be fused with lateral surface. And now, guys, it is not easy for our friend. Let's say very quickly: tenar, middle bed, and hypotenar. Three beds of the muscles: lateral, middle, and medial. Thank you very much. That's all today. You are greatly helping. That's why remember, please, by these two septas, all these both deep loose connective tissues, both, and subaponeurotical and subtendinous up to the bone, will be divided into three muscular beds. Yeah. One is lateral, we call it tenar. Second is the medial, we call it hypotenar. And one is middle, between them. Just 1 minute, I will go to my room and will come. Okay. One. Okay, let's continue. Can you open the last window? It's getting open. Push it to. Great. Thank you very much. Thank you. Okay. That's a fourth structure finally we described, which is originated from proper fissure. Yeah? Palmar aponeurosis, retinaculum flexorum, medial intermuscular septa, lateral intermuscular septa. Now let's come to the deep loose connective tissue spaces. Again, let's remember the tendon of our flexors split this deep loose connective tissue into two compartments, superficial and deep. And in its turn, each this compartment by two intermuscular septas split it into three muscular beds. Lateral one is tenar, middle one is the middle bed, and medial one is hypotenar. A little bit, let's remember your anatomy about these muscles. You can see that 4 muscles we have in the region of the tenar, 3 plus 1 muscle we have in hypotenar. Why I say 3 plus 1? Because musculus palmaris brevis is located superficially to the proper fissure, not under it. Another 3 located really in the region of the hypotenar, yeah? And finally, in middle one, we have 11 muscle. 4 it is the lumbrical muscles, 3 anterior interossal, and 4 posterior interossal muscles. Now let's start from the region of your tenar. You can see 4 muscles here. We have, guys, from down to upwards. It is opponent's one. Next one, it's mistake, guys. It is abductor, not ab. A short abductor. You remember that a long abductor located in your posterior forearm, in the deep layer of the muscles. Yeah, musculus abductor pollicis longus. Here we have musculus abductor pollicis brevis. Next one, it is the short flexor. long flexor located in the third muscular layer of anterior forearm. And the last one, it is single adductor. By the way, from all your fingers, only first one has adductor. Another fingers doesn't have adductor, but they have muscles which has the function of adductors. It is anterior interossal muscles. Anterior interossal muscles move all your fingers towards the third one. You see, third one doesn't change its position, but all others become to the third one. This movement we call adduction, and they perform not by adductor muscles, but by anterior interossal muscle. This movement, it is response of posterior interossal muscles, and we can call it abduction. So remember, please, anterior interossal make the adductional, posterior abductional. But first finger has its own and abductors and adductors. By the way, abductors is two, long and short. Long in posterior forearm, short in the region of the tenar. Adductor is only one. What we have in the region of the hypotenar, again, the same for muscles. The short muscle, it is become to the short palmar muscle. Yeah, it is the here. Superficial muscle. All others, it is one abductor, it is short flexor, and openness muscle. First finger has only abductor. It doesn't have abductor because I say adduction, it is response of anterior interossal muscles. On each side, we have four muscles. Lumbrical muscles, four, like for my fingers, but the most superficial. Under them, three anterior interossal muscles. Under them, four posterior interosseous. Yes. 4, 3, 4, 11. Is it understandable for you? Yes. That's all, guys. But don't forget that inside of subaponeurotical loose connective tissue, we have arterial arch and we have main nerves. When I say main nerves, I mean two nerves. Medially ulnaris, laterally medianus. Thank you. Let's start primary from these two nerves. These two nerves, ulnaris and medianus, inside of subaponeurotical loose connective, gives two types of the branches. Superficial branches come to the subcutaneous fatty tissue, and they make the innervation of your skin. And here they give, first of all, the common digital nerves, which is divided into proper digital nerves. And finally, we have the arrangement, which I say you before, 1 1/2, 3 1/2. 3 1/2 laterally will be innervated by medianus, 1 1/2 medially will be innervated by ulnaris. That's like in each margin of your finger will be one nerve. That's each palmar finger surface will have two nerves, one in the medial and one in the lateral side. Is it understandable for you? That single your finger, which will have different nerves in the palmar region, it will be your ring finger. Here, medially, you will have ulnar branch, laterally, you will have the radial branch.
Yes.
But except these superficial branches, the nerves gives also deep branches. If superficial branches is sensory nerves, deep branches is motor nerves. And they innervated the muscles which I mentioned. Now look here, please. Tenar muscles, except two, adductor and the medial side of the short flexor. All others innervated by medianus. Hypotenar muscles, together with two exceptional muscles, adductor and medial side of the short flexor, innervated by ulnaris. So once again, tenar by medianus except two, hypotenar by ulnaris together with two in the tenar. In middle side, two lumbrical muscles which is laterally by medianus, two lumbrical muscles which is medially by ulnaris. All interossal muscles innervated by ulnaris. Medianus doesn't have any tension to them. Is it understandable? Once again, Keep in your mind primary tenor by medianus, hypotenor by ulnaris, except two here, adductor and medial side of short flex. Middle bed together, two lumbrical medianus, two ulnaris, all interossal by the ulnaris. That's all. Finally, what I must explain for you, it is this picture, guys, and that is called the arterial supplement and arterial arches. As we show together with our friend, inside of each loose connective tissue space, we will have one arterial arch. In subaponeurotical one, we have superficial. It is shown here by red color. In deep one, we have deep arterial arch. It's shown by blue color. Now look to me. How the superficial arterial arch is formed? Again here. My hand, it is the tendons. Above the tendons will be superficial arch. Below the arch will be these two main nerves, which I mentioned before. That's the arteries located more superficially, nerves is located under it. But how this arterial arch is formed? By two vessels. First one and main one, it is ulnar artery, which by canalis carpi ulnaris enter inside of subaponeurotical loose connective tissue. But also here, that there are one small artery, which is originated from the radial one. We call it superficial branch of the radial artery. By the way, radial artery located inside of subtendinous loose connective tissue, and it gives the superficial branch, which is come to subaponeurotical. You can ask me how the radial artery goes inside of subtendinous space. Simply, guys, remember the forearm region. As you remember, in the inferior margin of the forearm, the radial artery turned to the back, comes to anatomical snuff box, then through the first interfinger space under the tendons and the proper fascia, entered into subaponeurotical loose connective tissue. And it gives here the superficial branch, enter into subtendinous loose connective tissue, and gives the superficial branch, which is come to the subaponeurotical one. Inside of subaponeurotical space, this superficial branch joined the ulnar artery, and together they forms the superficial arterial arch, which is in front of you. Superficial arterial arch, as you can see, gives four branchings. Now look here, please. First branch we call proper digital for medial surface of the fifth finger. Another three arteries in this picture is shown like number 1, number 2, number 3. We call common digital arteries. Common digital arteries come to the three interfinger space. It is second, third, and fourth. And here they divide it into proper digital arteries for each margin of your palmar surface. And they supply all fingers except first one and lateral surface of the second one. Once again, except first finger and lateral surface of second, all other fingers will be supplied by superficial arterial arch.
Yes.
Is it understandable?
Yes.
Now look into the deep one. As I told you before, it forms by the radial arch. But also look to this red interrupted structure. It is the deep branch of the ulnar artery. It is perforated. My hand, tendons, goes to the subtendinous loose connective, fuse with the radial artery, and it forms together deep arterial arch. What gives this deep arterial arch? If you will look to this picture, you will see that first of all, it gives one common digital artery to the thumb, first finger, which is divided into proper and supply both margins. Then it gives one proper branch into the lateral surface of your second finger to complete, yeah?
Yes.
But after, it gives some magical and understandable three arteries, which we call metacarpal arteries. You know what the function of them? It doesn't separately supply any finger. But in the region of the commissural aperture, because common digital arteries, red 1, 2, 3, pass through the commissural aperture, come to us. In the region of commissural aperture, they make anastomosis with common digital artery and finish it. And many times I show for you this movement, and I told you that then you press anything in your fist, superficial vessels can be closed while the skin color is changing. But deep vessels will provide the necessary blood supply. That's why remember these first, second, and third blue vessels, metacarpal vessels. They make anastomose with common digital arteries. Quickly conclusion. Deep arterial arch supply first finger and the lateral margin of the second one, and it gives three metacarpal arteries, which inside of commissural apertures forms anastomosis with common digital branches of superficial arterial arteries. That's all. We completely finished to discuss the palmar region. Now let's come to the dorsal. Skin. You know, guys, like I can say, how to say, etalon, most movable and most elastic skin of the human body, located in United Kingdom. If I will take this skin, look how much I can tense it to upwards. Skin is really very elastic and very movable. For the males, it's colored by the hairs. It contains fat and sebaceous glands. It has also receptors, not so much like here, but anyhow. Subcutaneous fatty tissue, it's bad developed, but you know it doesn't have any septa, it's very loose. That's in case of cardiovascular or nephrological problems. Here we can have accumulation of the liquid, swellings, edemas. Much more better it will be in dorsal foot region, yeah? But here, by the way, in both these regions, fat is bad developed, and in dorsal foot, and in dorsal hand region. But it can accumulate the liquids here, yeah? Big pads of the liquids can be formed in this region. In subcutaneous fat, we have the venous network, which I mentioned before, yeah? It is the place of origin of two superficial veins, medially basilic, laterally cephalic, as I keep in your mind and remember. Also, guys, it has superficial nerves. Now, if you will look, for example, in this picture, you will see two main colors. Green one, you know, green one we study in the palmar region, that is ulnar one. What is ulnar branches, which is come here? Before enter to the canalis carpi ulnaris, ulnar nerve gives the dorsal branchings, which is come to the dorsum of your hand. But what is the red color? It is the superficial branch of nervus radialis. Let's remember that in your cubital region, more exactly in the anterior lateral groove, nervus radialis split it into two terminal branches. Superficial one comes to anterior forearm, deep one goes to the posterior, through the canalis supinatorius, as you remember. Yeah? But superficial branch in the border between middle and lower third again goes to the posterior region. That's why we can come to conclusion that radial doesn't enter into your palm, it goes to your back. And superficial branch, together with the dorsal branch of nervus ulnaris, innervated the skin. Again, common digital nerves, proper digital nerves, and here everything is simple. 2 and half, 2 and half. 2 and half laterally radialis, 2 and half medially medialis. But look in the picture. Exception, it is the distal second, distal third, and half of the distal fourth.
Yes.
You can see that for these mentioned parts, we have yellow color. What does it mean? From anterior region, medianus continues to the back. And supply these distal three mentioned phalanx. That is exception. That is not from ulnaris, not from radialis, it is from the medianus. Remember about it. Superficial fissure, no any specificity, proper fissure. Forms here one, but very important structure, which we call retinaculum extensorum. It is again fused medially laterally with the carpal bone and gives many septas towards the carpal bones and divided this deep loose connective tissue into 6 channels. Inside of these 6 channels, primary we have tendons. Now look, these 6 channels is greatly visible here. Do you see? Retinaculum extensorum, which has this white, shiny fold, and behind of it the tendons inside the synovial. By the way, synovial sheets of the extensors located just below this proper fissure. In the metacarpal region, you can see they loosed. And then again, they recreated in the fingers. By the way, I want to remind you that in the region of the fingers, and anterior and posterior synovial sheets covered by the fibrous sheet. That's from outside of synovial sheath, web fibrous. And if you remember, this fibrous sheath has two compartments, so-called crucinate ligament and annular ligament. Crucinate is more loose and they located in the region of the joints. Annular is located between them. And in back and in front, absolutely everything is same. Now look to me. The first channel and second channel, a third channel, I can show in my finger. The first channel contained two tendons. First one, it is the long abductor. Do you remember I told you it is? And second one, inside of same one, it is short flexor. These two tendons forms anterior wall of your anatomical snuff box. So once again, in the first channel, there are two tendons, long abductor and short extensor. In third channel, I'm sorry. In the third channel, there are only one tendon. It is the long extensor. That's a short extensor located in first. In the third one, located in long extensor of your first finger. There is second channel. It is in floor of your anatomical snuff box. It's not good palpable. And it contains two tendons, extensor carpi radialis longus and brevis. Hanaja. Че, аз хаджа учундес. Да си, давай, цата. Channel number 4 is located in mid-side. It contains two tendons, extensor digitorum and extensor digiti indici for your second finger. That's why it is here. Channel number 5 contains one tendon, extensor digiti minimi. Channel number 6 contains one tendon, extensor carpi ulnaris. So remember, please, inside of the fourth channel also we have interosseal vessels and anterior and posterior. I want to remind you that posterior immediately located in the back, anterior one in the border between middle and lower third, perforated interosseal membrane and come to the back. And from here they will pass behind of the proper fissure, will come to the metacarpal region and will form the arterial arch of the dorsal region. Again, common digitals, again, proper digitals. That's a finally, guys, each finger, 4 arches, 2 in the palmar, 2 in the dorsal. 4 nerves, 2 in the palmar, 2 in the dorsal. Means 4 neurovascular bundles. That's if you make the surgery of your fingers, you must, for example, in condition of local anesthesia, or regional anesthesia, you must make injection in 4 points. Anterior lateral, anterior medial, posterior lateral, posterior medial. Please understand. I do my work. All hand region I explain for you. Questions? Do you have any questions? No, any questions? You are happy persons, guys. 2 options, or you can leave my room, or you can sit in my room, but in both cases you should keep silence. Guys, I'm absolutely honest to myself, to my soul, because all my work, point by point, topic by topic, I explain and give for you. I can't imagine what else I can do for you. No, I can imagine. If you will come and ask me the questions, I will be happy to help you. That's single my more option which I can suggest you for next hour week. Unfortunately, it will be very hard to catch me. So you understand that you are not my single group, and all another my groups also in the next week have the midterm exams. But technically you can come after 3:30 and try. For your group also, guys, now look to me. I'm not sure that during the practical class I will finish everything. So possibly, I will touch wood, of course, I will do my best to not have it, but possibly we can continue our work after the lesson. For example, if some student will not have the chance to pass the control during the lesson, they will come after all the lessons. Do you understand me? Friend, you have the problem with the... Can you repeat what I told you?
those who didn't pass, they can come after exam. Those who didn't pass, they can come after exam.
After exam, it means
After
that.
classes, all classes.
Brilliant, thank you very much. You proved me that you are right. Great, thank you very much. That's all. Short questions, short answers. Don't tell me anything which is outside of your questions. That's all. Do you have any questions to me? Goodbye. Goodbye.